Good afternoon. I just want to say what an honor it is to be here to represent my team from Red Deer. I am a very optimistic person, and I have to say that we have done better than I ever thought we would do, and I am just so proud of us as a group. And another thing I want to tell you, I know we've heard a lot this morning about how well we're doing with this initiative in Alberta, and I just wanted to add to that because I always tell my parents who are still living in Ontario about the things that are going on and what I'm doing in my career, and I told them about this project, and about a month ago they had cut an article. They always send me articles about neurology, it's cute, and they'd talked to me about an article in the London Free Press about how well the London hospitals were doing because they had a door-to-needle time now of 70 minutes, and they were on the forefront of stroke care in Ontario. So my parents wanted to know if they should write a letter to the editor to let them know that actually Red Deer had a door-to-needle time of 30 minutes. And I said, you know what, Mom, we're going to let this one slide. And so just to add to that, I just thought it's just amazing to see the work that we're doing. So without further ado, I'd like to tell you that I did not name, whatever's on your agenda, I did not title that showing that what a smaller community, how we show tertiary centers what to do. She did it. I wasn't trying to show anybody, but I was just trying to show what we could do in Red Deer. So we're going to start with what we used to call stroke in Red Deer was hyperacute stroke. And now, since this initiative and in developing things over the last year, we now refer to this as stat stroke. So just wanted to show a beautiful picture of Red Deer Regional Hospital. And this is our central zone. So I think there was many things that came together to make this a really a good success story for us this year. But there had been previously only 3 neurologists in the area, and in 2015 that expanded to 5. So of course that made it much easier to have complete coverage for the neurology service once there was 5 of us as opposed to just 3 of us. But when we, at the time QuiCR started, there was a variable hyperacute stroke protocol. In terms of just what was going on, we've had double the stroke admissions in the past 5 years. In 2015, 392 strokes and 9 TIAs. On average, we have 35 acute stroke admissions per month. So it is a fairly busy service, and the TPA volumes are a 2 to 3 time increase since 2009. So we are pretty busy, and if you see the central zone, I put this on, it's, I don't know if you can see this well, but we have a large catchment. So often when we're on call, we get calls obviously from Rocky Mountain House, from many outlying hospitals. So we do have a very large catchment area. All right, so the protocol pre-QuiCR, as I said, it was a variable protocol, and many of the things that were talked about earlier were some of the things that we made significant changes in. So obviously the EMS made a call to triage, or there was a walk-in stroke. The patient would arrive to triage, and that's when you would get an overhead page, hyperacute stroke. The patient would be then registered. The patient would be taken to the trauma by EMS. There would be that bed transfer, which I think Tom had talked about, and we were able to improve on that quite quickly. But the patient would be transferred to the bed. There'd be a detailed verbal report. There'd be a comprehensive assessment by the trauma team, which was mainly initiated by the emergency doctor. So when we first started out, neurology really wouldn't be involved at that point. The ER doctor may or may not order a CT scan. The ER doctor may or may not call the neurologist at that point. And so there was a large variability. The labs would be drawn often before the patient even went for a CT. They'd be waiting for the labs to be drawn, or a catheter to be put in, or a chest x-ray, and it was sort of all over the board. The patient would then be transported for a CT and CTA, arrive back, and it was often at that point, as I've worked in Red Deer now for 7 or 8 years, and it would often be at the point after the CTA and was done that then I would receive a call. Then I would come in, then I would have to do my assessment and decide whether or not the patient would receive TPA. So it was a very sort of linear process, and the times are extremely variable. So then what did we do? And keeping in mind that we wanted to have the fastest optimal time, and that certain results suggest that very few people, or 34%, we've talked about this, were getting it in less than 60 minutes. Our door-to-needle time from January to June 2015 was 72 minutes, so well over an hour, and that's just median. So we had lots of room to improve. So how do we prepare for QuiCR? So even before QuiCR started, what I did, and I don't know what people have done at other sites, but it was in, I think, May of 2015 that I took over as head of neurology for the Central Zone, and I just asked the other department heads, radiology, I should say, emergency physician, and we all got together to have a roundtable discussion about the fact that the QuiCR project was going to be coming out in the fall, so that I could get some of their feedback, because we need to have the buy-in of the other physicians. I think some of the delay in our treatments, we're having some buy-in from those physicians, either the radiologists thinking, we don't really need a CTA, and I'm not laying blame, or just the emergency doctors not having the belief in the TPA, maybe in the Central Zone as much as I would hope that they would have. And so just getting all those key stakeholders together to say, you know what, this project's coming out, we're going to see what we can do, let's work together, and that I think was very helpful as sort of a first process, even before the QuiCR started. That we then started to think about a protocol, and then and that was sort of the first step before the summer. I think a lot of what helped us to develop things was that we had regular meetings with regular feedback to sort of keep the ball rolling throughout the year. We've seen this article many times throughout the morning as in being quoted, but I actually did take it, and I actually wrote it out, and I took all the key points that I thought from our old protocol that I thought we could change, and we really did try to incorporate as many of the suggestions in this article in one particular table, I can't remember which table, and we really did implement them in our protocol. And I think it's made a huge difference. So when we think about how we changed our prior protocol, we had sort of 4 broad areas of improvement. We made huge changes to the pre-notification stage. We made changes to the patient arrival, imaging, and then post-TPA and feedback. And it's interesting because, one little change in one area doesn't count for much, but by the time you make several little changes in several different areas, it accounts for a lot of time. And I can say, and as you're going to see in the graphs, we did go from 72 minutes median when we started this to 30.97 median for 2016. So it can be done with small little steps. And so we'll go through sort of what we changed. Okay, so fast treatment. So really what we did was parallel treatment. So instead of that long list of things being done, we started to do parallel rather than serial. And I know you can't see this, so it's really not important. But what we've done that's different now is sort of the most important thing for us, I think, now is the swarm. And that's where all the key players come together and do the assessment at the same time. So the neurologist, if possible, if we have the pre-notification, the neurologist is notified at the same time. The radiologist and any of the CT techs are notified in advance. The whole trauma team is notified, the emergency doctor. So we're often there at the same time. So the emergency doctor will come in, we'll both do a parallel assessment. The emergency doctor will ask if I've got this, and then hopefully I say yes, and then we take it from there. And so the swarm for us has been, I think, really key to making everything move quite quickly. So if we then break it down into the pre-notification, we've got, of course, the EMS contacting it. Then they activate the emergency department physicians, nurses, neurologists, and DI tech. This is going to be so important because as we do the endovascular therapy, as we move forward, the triage nurse is going to be very used to, activating the protocols, and so she'll be able to then, as we talked earlier, contact rapid if needed for patients with high LAMS scores. We'll talk about that later. But so the pre-notification gets done, then The other important part is our protocols are right there at triage. I'm not sure how they do it. You do it in other places, but our algorithm is right there for them to go through. It's posted in various parts of the department so that people know their exact roles. So that's our pre-notification. Then, as I said, the swarm is so important, the parallel involvement, consistent flow. Often I'm doing my NIH score as they're trying to put the lines in. They're staying on the emergency stretcher. The EMS is giving me their history as I'm doing my NIHSS. At first, it seems like it would be a little bit of chaos, but after you've run it a few times, it actually is organized chaos, believe it or not, and it's quite quick. We are using standardized forms, and it makes everything very fast. Obviously, we don't put a catheter in anymore, and then it's as fast to go and get the CT as possible. So then, as we said, down they go. We do the CT, CTA quickly. We don't have to wait for some of the blood work. Don't wait for the formal radiology report as long as there's no looking like there's a bleed. We don't have to wait for all the laboratory reports. We have given TPA in the CT room. We don't always give it in the room because ours is like a 1 minute. I think that Michael was saying that it's like 19, or there's a huge 15 minutes or something up in the foothills. For us, it's not. It's a little run down the hall and back, so it's literally 1 minute. So often, depending on what's going on, I think they're still a little bit nervous, some the CT tech's giving it in there. So sometimes we'll just call down and say everything's clear. They'll be mixing it in the trauma bay while we're coming back, and there's not that much delay, in all honesty. I think I've given it a couple of times. So then we have the post-TPA feedback, and I chose the superheroes because I guess I couldn't find an angel, but the TPA feedback is quite important. It was quite interesting, and I'll use Shelley's example because she was here this morning, but she was the fastest I'd had at that time, and the whole team was very excited. It was like something really exciting was happening, and I kind of almost felt bad for Shelley because everyone was so excited, and everyone was talking about getting their pins because we have these pins that time is brain, and we have these pins for 30 minutes and 25 and 20 minutes, and everybody was wanting their pins and who was going to get their pin, and I deliver the pins to the CT techs, and I deliver pins to the radiologists, and I deliver pins because these people are the people that don't get the feedback, right? They're the people that don't know what happens. They aren't like me who gets to see Shelley the next day when she's able to walk, and so they wanted their pins. So Shelley's on the bed, and I'm apologizing that everyone's so exciting. People were high-fiving. She's like, "Do I get a pin?" This is Shelley on the bed. "Do I get a pin?" I'm like, "You can have a pin, Shelley." So it was a little, but that is the feeling. And stroke never used to be that feeling in Red Deer. And it used to always be that feeling that we have this amount of time. We can take our time because we have this amount of time. Now it's the opposite feeling. It's like we only have this much amount of time because we want to get our 20-minute pin. It's really nice. It's a whole team approach, and we wouldn't have been able to do it without the whole team buy-in. We really wouldn't. So there's the pin, and I was going to wear a pin, and I couldn't find it this morning, darn it. But anyway, I think I have my 20-minute now. So just so you know what else we have a board in the emergency department, our communication board. So it puts up our data so that anybody can go and see and get some feedback about what's been happening. And it's really interesting because even at the table amongst us today, they're like, "Did you know we had a door to needle of 18 yesterday?" I said, "I already heard that." So that's what goes around the hospital, right? And so there's a stroke neurologist at our hospital now, OJ, and he and I have a friendly, we're both on call quite a bit, so we have a friendly competition about who's going to get the next fastest door to needle time. So it's a healthy competition, as Noreen had said. So there's our communication board. And then 3 site visits, and I really do think these were pivotal. We've had neurologists for a long time, and despite having neurologists at our center, we had door to needle times of 72 minutes in 2015. So what was different about what happened in 2016 to make our times go from 72 minutes to 30 minutes. What was different? We had a meeting where the powers, the QuiCR project team came to talk to us about the importance of what was going on, to have buy-in. And I think Noreen mentioned it truly, they spoke, and we said, we're going to do this. This is when we're going to roll this out. And there was some nervousness in the crowd. How are we going to do this? Couldn't we have 45 minutes? It's true, that was one of the questions. There was some worry that we might miss something. What if there was some serious AAA that came in and it got missed, or, if we go in a hurry, But then, so I was quite nervous after that meeting, thinking nobody's going to really want to do this. But then the dust settled a couple of days after the first meeting. The next thing I know that they're going to do a sim. A couple of the really energetic nursing staff in the emergency department sort of took this as their, championed it and organized some sims. And we got the ball rolling. And from there, it was really just getting everybody together, giving the information, and then having the whole team buy in. And so first meeting we had in the fall, and then we had another, so just the first small meeting was just with a small group. Then the second meeting in the fall was a big group and a dinner. And then the third meeting, which I think went really well, was in the spring, and that was the feedback session. And if you do anything as a group, even if you don't have the team members of the QuiCR are able to come, I would really strongly suggest that you do that at your own sites, because this is where we had Shelley come in for the first time, and all of the DI staff came, all of the other people who are involved in the care of the patient and trying to make their care as quick as possible, but that the people that don't get to hear what happens to the patients, and really there really wasn't much of a dry eye in the room, because she's a 46-year-old mother who has no stroke risk factors other than migraine, right? And you're not expecting a person like that to have a stroke. And when she came in, she could not move her left side. And she can walk up here, and it's even hard for us to imagine when she's here talking to us, right? She could have been disabled for the rest of her life. The nice advantage for her was, it's maybe good EMS couldn't get there because her husband drove her in, and she was at the hospital within about 5 minutes of her stroke. So she may have gotten her TPA in 23 minutes, but she really had her TPA within about 27 minutes to 30 minutes of her stroke. So you showed some diagrams and things showing the faster, like she wasn't at home for an hour waiting. She got fast TPA, not just 23 minutes, but from stroke onset. And I really do believe that's why she's done so well. But having that kind of feedback, and for people to know that moving quickly and doing things fast is not just about a pin, it's about someone's life, I think it makes a huge difference. She really did have a great experience with early supported discharge as well, which was nice. And it was the first time she ever admitted today that she was so scared, because she did put on a brave face when she was in the hospital. She's a very outgoing person, and so I was actually surprised she even admitted that today, but it goes to show us that patients don't always tell us what they feel, right? And I had mentioned the simulations, and I think that made a big difference for the staff in the Emerge, for some of the things that they were worried about as to how it was going to go. I didn't do the simulations. Dr. OJ had done them with the team. Again, it was from start to finish just as we would expect. I don't know if we had any door-to-needle times for those. Are we better in real life, Elaine? Good. That's what I like to hear. But it was good for them to run through it to know what to expect, right? And then in this past spring, we've actually, it's part of their annual education now. So not just did we do the simulations last fall, now all the ED nursing staff have to do these simulations as part of their training. All right, so just the current algorithms. So of course, like anything, this is a work in progress. Did we make a perfect algorithm the first time? No. Do we have a perfect algorithm now? Probably not. So we've, the latest version came out in June 2016. As we said, ongoing development depending on some feedback. I was just saying to them today that we're really great. There's always things we have to tweak. The other day we had a pre-notification. I knew the patient was coming in, but accidentally in the excitement, we forgot to get the patient's name. So as they were waiting, but I didn't know anything about the patient, I couldn't look them up because we just forgot to get the name. So there's always things we can improve on. So we have a stat stroke triage algorithm and then a stat stroke trauma bay algorithm. So we have two separate algorithms, one that's right at triage when they arrive, and then one that's in the trauma bay where we see the first patients. And so, as Tom had mentioned, every site is going to be individualized, right? The important thing is to have one and have it accessible so that when something comes, you've got it right there and the staff knows exactly what to do. So that's the one at the triage, the one in the trauma bay, and our goals are on there. Our main goal of door to needle time of 30 minutes in the top corner up here, and our goal of door in, door out to be 45 minutes. And that's in the hope if we need to send somebody for endovascular treatment. And so the other ones are in detail in the back. So what's our local progress? And so I like this because it shows the right trend. And so this is just the year, the access is the year. We started sort of recording back here in 2008. And then you can see in this red line is our median door-to-needle time. And as you can see, for 2016, a door-to-needle time is 30.97. And when we started way up here at 101 back in 2008. Of course, there's outliers and things happen, but yeah, we've done phenomenally. And so just to give you some data, so this was every TPA case for 2015, and this just gives you a sense, and we're not going to go through all of it. So this was all of our cases, and so just to get a sense of what's happening, this line here is this black long line is the 60-minute sort of goal. And then here is the QuiCR target of 30, as you can see down here. And you can see we're all over the board, and this is where QuiCR started. So once QuiCR started, you see that we were much better, and the red is the door to needle, and then the pink is the door to CT. So you saw as soon as QuiCR started, we got much better. We had one case which was an outlier due to patient factors. But anyway, so that's 2015, how things went. And then if we look at the data for 2016, all of our patients, 100% are under 60 minutes. 100% under 60, no outliers. There were, I think, 5 patients that were outliers that are not included in this because they had strokes while in hospital or other situations which didn't meet criteria for QuiCR. So just so you know, I'm not cheating, but they didn't meet the criteria for QuiCR. So all of the patients in 2016 that were treated in Red Deer had door to needles under 60, and this is where our median gets to be 30.97 up to mid-September, I think. And then just some of the QuiCR graphs we won't go through, but this just shows our data, our improvement for the entire time of QuiCR. Again, some of the outliers. This was somebody who had a basilar stroke that wasn't recognized, came in as something else, went up to the ICU, and was TPA'd in the ICU, so still counts, but wasn't actually recognized as a stroke. But all the rest, as you can see, are well within our goals and time frames. And then I just wanted to have this month because it was a particularly good month, our July month. So these are our other data, but our July, I think our median was like 22 or something, right? So that was a really good month. I won't tell everybody I was on holidays that month, but I think OJ was covering most of that month. But anyway, our stroke neurologist. So, and then, yeah. So this is my last slide, future directions. I'd really like to see something happen with door to needle for inpatient strokes. That is a big area of improvement, something I'd like to see develop down the road, because certainly we have protocols in place at the hospital, but they're not followed with any speed, that's for sure. Again, some issues that are still things like remote viewing, the rural referral process. We're still having some patients at hospitals like, say, Panoka, getting directly referred to CT instead of calling the neurologist on call. And then all of a sudden, there's a patient with an acute stroke in CT that I don't know anything about. So we're working on that. We're working on neurology coverage, of course. Even with 5 of us, it's still hard to cover 365 days a year. Again, we're going to be working on the door in, door out for endovascular. And then the last slide, I just want to say thank you. Again, it was truly a team effort. I couldn't be more proud of all the things that have been going on in Red Deer. It's just a wonderful place to work. I love it there. Thank you to the QuiCR project, the SCN, all the administration, and thank you for having us speak today.